So let's move on to the next session. Not to miss this PUO. The presenter, Dr. Reepa Agrawal. May I call upon our moderator, Dr. Amdekar, sir, please. Our panelists, Dr. Malathi, Dr. John Matthai, and Dr. Fazal Nabi, please.
I think we get going with the presentation. It's a 20-minute slot,
Yes,
so we'll just make out whatever best we can make out in this short time. Come.
Yeah, good evening, everybody. I'll be sharing this case. This was a 2-year-old male child, first by birth order, born of non-consanguineous marriage, came to us with chief complaints of fever. He had fever since the last 2 months. The fever was intermittent, mild to moderate grade in intensity, 2 to 3 spikes in a day, responding to antipyretics. The child was active in the interfebrile period. There was this fever was not associated with any chills or any rash. There was no history of cough. There was no history of abdominal pain, diarrhea, or constipation. There was no history of burning micturition. There was no history of joint pain or photosensitivity. And also, there was no history of recent travel to any forest area. On inquiry, although there was history of animal contact present, there was a pet cat. The child was referred to us after almost 10 days. He was admitted outside and he had received IV ceftriaxone for 10 days. Fever had subsided after that for 2 to 3 days but recurred again. That is when we got the opportunity to intervene. Otherwise, birth history, development history, immunization history, diet history were within normal limits.
Well, I think at this point we can't make out much. Okay, some prolonged fever. How do you guess? It could be anything. Let's get to examination straight off and then discuss.
Okay. On examination, the child was alert, active, playful, vitals were stable. Mild pallor was present. There were tiny submandibular cervical lymph nodes present. There was no icterus, no edema feet. On anthropometry, his weight was 10.2 kgs and height was 82 centimeters, which the weight lied in between the 3rd to 15th centile and the height was between the 15th and the 50th centiles. On systemic examination, on per abdomen examination, there was organomegaly present. The liver was palpable, it was firm, it was non-tender. It was 2 centimeters below the right mid-clavicular line and the span was 8.5 centimeters. The spleen was also palpable. It was firm, 3 centimeters below the left mid-clavicular line. There was no free fluid appreciated clinically. And other systems were unremarkable, they were normal.
Dr. Fazal, would you take this first?
Yes, sir. 2.
2 years old child with fever for 2 months and who is active and playful and received antibiotics and something infective process which is evolving disease which is going on almost for 2 months with no other symptoms except on examination he has got spleen and liver. Both are firm and no other symptoms and no other system involvement. At this point, just clinical impression is something chronic, evolving disease, more of infective or infiltrative or inflammatory disease. Further, I need to do further investigation or any other clinical examination finding developing with the time. That's what we have to think at this point.
John, do you think this is infection at all? 2 months story, not localizing anywhere, failure of antibiotic. Why do you call it an infection at all?
Difficult to say at this point that it is an infection, but I think that's a commonest in our country, so I think infection would still come quite high up. There's nothing to suggest a liver disease, so the liver and spleen to me would be an enlargement because of a reticuloendothelial hyperplasia rather than a primary liver disease. And reticuloendothelial hyperplasia at this stage would still involve typhoid and malaria and leptospira and infectious mono and all those sort of things come in. Was the child given typhoid vaccine?
No, sir.
I think typhoid
Was not given.
He was not given, sir. He's just become 2 years, like.
He was just 2 years old.
Yeah, yes.
Right. I think it's difficult clinically for me to say anything more than that. He's a very well-nourished child and he's come after 2 months.
Yes.
But at the end of 2 months, he's still pretty well-nourished. So Obviously, the illness hasn't taken a very heavy toll on him.
Malti, do you agree that typhoid, malaria, leptospira are all out? 2 months story. The child is still holding on, nothing happening elsewhere.
Because of the no jaundice, and yet there's hepatosplenomegaly and nodes, more reticular endothelial involvement, but fever. So I'll still put infection. We have to think of tuberculosis in our country and EB virus, but we should think of other possibilities also which can go on for a long time, like infective and inflammatory. Even a JRA, we have seen children presenting a connective tissue disorder presenting. It's an evolving disease. So I think as you go, you will be able to pick it up. It's not a sick child.
I think one thing I found fascinating in your presentation was that you said that the child was well in between the febrile episodes.
This,
That's a bit of a giveaway in favor of one of the diagnoses which Dr. Malthi
one thing
suggested.
is 10 days of antibiotics sometimes, you know, it changes the course of illness, some symptom, you don't get your findings. So I think we need more biochemical investigations or something like that which will give us a clue also.
Yeah, here acute bacterial infections are out. It's a 2 months illness. Typhoid is self-limiting 4 to 6 weeks illness. Malaria is out. I think we are dealing with something infective, chronic bacterial. Presenter has said that cat scratch, history of exposure to cat scratch, that is a diverting point. That also is self-limiting, subacute, lasts for 4 weeks, largely without fever. Hardly some regional lymphadenopathies.
Any audience participation? I thought it could be histiocytosis. Why are we looking at infection at all? It's an infiltrative disease. Okay, one of them is histiocytosis. Could it be a storage of any other kind?
The fever.
Why are we looking at infection alone? Which infection is going on for 2 months without telling us anything that's happening? Any comments on that? Would one of you take it? Why not histiocytosis?
I would have expected the child to be sicker by now. So the child is quite well.
Because yes, we usually by this time, even though the fever, brucella is one possibility which we could think about. HIV we have seen, hepatosplenomegaly, fever, and then you get the... So in our country, I think infection, we still have to think of that, exclude that, and then we can think of other.
Malti, at this point of time, it's fine. 2 months is a long story. I think the mistakes that have occurred in the past makes us wiser. But let's look at 2 weeks of age. Suppose I gave you this child at the end of 2 weeks, ceftriaxone has failed. This simple investigation routine have not shown anything. What would be your take-up on further investigations?
First, a CBC is very important. We don't have the count. I think a simple CBC and a peripheral smear should be done in a 2-week child with hepatosplenomegaly and lymph nodes. I think without that, we should not progress.
So let's look at the investigation.
Good peripheral smear.
A peripheral smear, yes.
Yeah.
So on summarizing, we had fever since 2 months with HS megaly without jaundice or lymphadenopathy or significant anemia. And the patient had already failed a trial of broad spectrum antibiotics.
Yeah,
So-
go ahead.
So
Give us the... No, leave that for a while.
Okay, sir.
Get on to... Yeah, that's right.
So on investigations, the first investigation was done outside. The hemoglobin was 8.2, total counts were 7,900, polys were 42%, lymphos 52%, platelets were 98,000. This was the CBC outside. When the patient presented to us, it was the second set of investigations on 13 July. The hemoglobin was 9.2, still on the lower side. Total counts were 11,000. Polys were 63%, lymphos 37%. Platelets had improved 1,43,000. ESR was 13. SGPT was 335 and SGOT was 214. Alkaline phosphatase was 254. Total proteins were 7 and albumin of 4. PT-PTT was normal. And LDH, uric acid, LDH was slightly on the higher side, 690, and uric acid was 4.6.
John?
It's a primary, there is some liver involvement, but unlikely to be a primary hepatocellular disease. I would think this is something secondarily that is involving the liver. I'm curious to know what's happened between the 13th and 26th, what treatment, because the ESR seems to have gone up to 95 and then down to 19. Was it a mistake that 95?
It seems to us also, sir, because that was only in a duration of 4 days, 13th July and 17th July.
Yeah, it seems something is...
I think when there is so much of discrepancy, we will probably not discuss it. It's very unlikely that that is right. one of them must be wrong, so leave that for a while.
The LDH is high. Am I right?
Yeah,
Yes.
690.
690, and then it's gone up to
1012.
Right, that's a little suspicious for me, and I would be looking at it a little more closely for watching that LDH. Serum ferritin is normal. So hemophagocytosis and all those things would probably get away from my mind. So something that is not a primary liver disease, but something that's also involving the liver with a very high LDH level.
Malathi?
Yes, there is definitely involvement of the liver because without a bilirubin being high, there is a hepatitis. The cytoplasmic injury is definitely there, which is very well documented, and a drop on the hemoglobin with an elevation of LDH showing probably there's some amount of hemolysis. We are not too sure. But the other factors are not there. Prothrombin time is normal, so it's not a primary liver disease. It's probably either a systemic disease involving the liver or an infiltrative disease. Not an infiltrative because alkaline phosphatase is not high. For that age, it seems to be normal.
Was the peripheral smear looked at, because that's a
Yes, sir.
persistent anemia?
Yes, sir.
Can you
Yes,
just
sir.
tell us what that anemia is all about?
So it was microcytic hypochromic anemia, and otherwise the PS was normal. Only the microcytic hypochromic anemia.
But there's no thrombocytosis. So
no,
unlikely
no,
it's
so
an
there
iron
was
deficiency anemia.
thrombocytopenia to begin with, and then
Correct.
later.
So it's not unlikely to be an iron deficiency anemia.
Retic count was done?
Yes, ma'am. Retic count was 0.3%.
So there's a microcytic hypochromic anemia without thrombocytosis.
Yes,
That
sir.
would make the anemia maybe more likely to be, how much was the MCV and all that?
So
Was it severe or was it mild?
MCV was 73.
So it's quite mild. So the anemia is out of proportion to the microcytosis. Because normally in iron deficiency anemia, we would expect thrombocytosis.
Yeah.
Now we don't really find that. So I'm
With
worried
the
about
setting of infection can still be expect thrombocytosis.
something that's also involving the marrow. So
John,
Yes.
but most of our children have iron deficiency. They start with that. You get another chronic illness, the whole thing changes. So probably that may not give us a clue where we are heading at. Fazal, you have something to say?
Yeah, here differential diagnosis about eosinophils and monocytes, that also can give us little information.
Okay.
Another thing is SGPT, SGOT ratios are something, and second report is altered. Like SGOT is going up. That means it's not primary hepatocytic involvement.
Yes.
It's a reticuloendothelial system. That is the RE cell involvement is more higher with LDH elevating.
There is a possibility of malarial hepatopathy which has been reported, though we usually say malaria is called due to falciparum and we have hemolysis with indirect bilirubin. Sometimes you can get malarial hepatopathy even with Vivax when you can have the transaminases elevated, the hemoglobin dropping. So I think we should still...
can you tell us that peripheral smear report once more, or are you hiding it from us?
No, sir. I'm not hiding anything here.
Ultrasound.
So I think at this point we seem to agree that it's a systemic disorder with some liver involvement. We are not sure what systemic disorder we are heading at, and we are just groping in dark. Probably it doesn't look like an infiltrative disorder, doesn't look like a malignancy of any kind coming up. So probably an infection at this stage. If that is so, John, what's your next investigation?
The cat.
Parvovirus.
What's your comment on that?
Parvovirus, yes, that hemoglobin drop could, but that age group usually we don't get, and
I think
no
don't worry about
there's no
hemoglobin drop.
progressive
It's
drop.
not a big drop. They are drawing blood every now and then. Yeah. So I don't think it's a pathological drop. So I won't worry about that.
And there's no drop actually, it's been static. From the beginning it's 8.2 and 8.4, really it isn't there. And I think that cat is just a diversion to take us somewhere else. I think.
So what
the
next
poor cat,
investigation
huh?
now?
You
And
have
we have
done a blood
repeated-
culture which was...
Yes, sir. You want me to show the further investigations?
So what are you expecting? Still a salmonella? Or any pseudomonas? What are we expecting now? At the end of 2 months of fever? Why do you want a blood culture?
The ESR is quite low. So that's another thing that worries me. In spite of 2 months of if at all if it's an infection, I would have expected the ESR to go up. So the ESR is remaining low. So I must look at if it's an infection which gives you a low ESR.
What's the role of abdominal USG at this point of time? You want to see what the liver and spleen looks like, or if there anything else in the abdomen? You might have a lymph nodes there.
No, I'm sure they would have done an ultrasound before this. They wouldn't have waited till 26. There must be an ultrasound done on 14th of July itself.
You have an ultrasound report?
Yeah,
just show that.
Sir, before that, from this panel, can I make a comment, sir? Go back to the panel. Go back to the previous slide.
The previous one he wants.
Yeah, if you see the differential count, it is lymphocytosis always. Despite having TLC being 18,900, this is lymphocyte predominance. And OTPT, LDH, if you don't give me the duration, I will still put my money for typhoid. And this picture can very well be fit with the typhoid. Only what feature is the 2 months duration and safe traction. But if you give only interpretation of this panel, sir, there are many features to suggest enteric fever.
EB virus also can have that. IgM EB, that's also a possibility.
But I think if I look at these polys and lymphos, I would say that it's not really interpretive. Okay, they're just sitting very close to each other. There is no significant lymphocytosis to talk about that. It's probably a clue. So you have an abdominal ultrasound.
Yes, sir. The USG abdomen initially when we had done, that is on the 14th of July, was normal. And the rest of the investigations for the fever workup they were essentially normal. Urine routine was normal. PS for MP optimal were negative. The blood culture as well as the urine culture were showing no growth. Vidal as well as the extended Vidal were negative. Cox workup was negative, HIV was negative, and chest X-ray was also normal.
Now what do we do?
Since you said since you have said the ultrasound is initially normal, I suspect something is...
John, you are very observant. Yes.
Initially normal.
Yeah. So what are you looking at again in the next ultrasound? Let's look at that. Yeah.
In the liver ultrasound.
Or do you want a CT scan?
Maybe for a space-occupying lesion in the liver or lymph nodes or abscess, something like that is what I'm looking.
So they're looking at a liver or maybe micro abscesses or maybe infiltration in the liver. That might give us an idea where we are.
Not high. Alkaline phosphate is not high, but still we would like
Yeah,
that
but
before a liver biopsy.
The LDH is high. So that again is something that I would worry about. That's the point that I made about the LDH there. So
have you ruled out TB at this point of time?
What have you done for tuberculosis?
Cox workup was negative, Montu was negative.
Hepatitis presenting as PUO, you have very high alkaline phosphatase. That's one of the pointer to say that. So we don't have that. There are no clues. So it's again going to the dark. But I think the ultrasound before we decide whether we want a bone marrow or we want a liver biopsy, because I think we have to look at these two before we make a diagnosis.
So let's have another ultrasound.
The second scan showed increased ecotexture of the liver, suggestive of liver parenchymal disease. We also did autoimmune workup, which was negative. 2D echo we had done just to rule out infective endocarditis as a PUO workup. Bone marrow aspiration was also done, which was within normal limits.
I think at this time we must remember that every time we want these test results, we also need to discuss with these people. We need somebody equally conscientious to look at, and unless we tell the sonologist what we are looking at, he won't look at what we want him to look at. Okay, and I think this is very, very common at this end of all this story. We are not sure, though we are groping in dark to say it is a systemic disorder, it's probably an infective disorder, and we are talking about maybe TB, Malathi said brucella, but we are looking at some proof of that. Now let's boil down to say TB or brucella. Okay. Now what another test now? You think a liver biopsy?
Brucella antigen has not been done.
No, ma'am, it was done with the extended Vidal. It was negative.
HbSAg is negative.
Increased ecotexture of liver was right through the liver, or was it an area of increased echogenesis?
Generalized.
The entire liver.
Biopsy.
Only tiny submandibular lymph nodes.
But no nodes in the abdomen?
No.
I'm sure if clinicians differ so much in their opinion, sonologists also must be. But one sonologist puts up a report and we go all by that. So I think that's the limit. Let's see, what did you do next? Yeah, tell us what's next.
Liver biopsy, aerobic.
We had sent an aerobic blood backtake, which was awaited, although the initial blood culture was no growth, but that is not, at that point of time we had conveyed to the microbiologist not to discard the culture. And that is when on day 11 we got the report of Brucella species.
Correct. Yeah, I think whenever you have negative cultures, the lesson here, we have to request a microbiologist to keep that culture. Because Brucella can grow anywhere between 2nd week to 4 weeks of your culture media. Same blood culture. You don't need a special culture media. Same blood culture takes 4 weeks to grow that culture. Simultaneously, you work up next further investigations, serological and other investigations.
I think that's a very important point. Brucella takes a long time to come up, and I think nobody is going to wait till few weeks and you move on to something else. But I thought that some other features could have been picked up maybe. For example, often there is a biliary tract obstruction. You might have a high GGT coming up.
Globulin
if that is so.
also.
Generally, I think in a Brucella, you
Globulin,
don't have high.
Globulin is high. Usually we pick up a high globulin and that gives us...
This child didn't have a high globulin.
They didn't
No,
show
sir.
No.
It was 3.
3. Globulin was
3.
Globulin was not
not there.
what high.
Fine. So we'll just end up by saying that we knew that it was 2 months prolonged fever, probably infection, probably extrahepatic infection, systemic disease, liver involvement, but it takes so long time to pick up everything correctly. And I think this is one of the examples how it could really baffle all of us, though every one of them said that they were thinking of some infection, but that was not showing up. Thank you very much.
Thank you.
Thank you, sir.